just made some alterations to the slides to incorporate some of the talks that have been covered. So that's why we are trying to change the slides a little bit in order to cover hopefully what we want to discuss today. I think quite a lot has been mentioned about pediatric leukemias or ALL treatment, and I'm going to cover what has been learned actually over the last 10 years and see how we can actually try to apply this in general. Thank you to the staff for allowing me to change the slides a little. So the treatment results for childhood ALL has improved really in the West quite a lot. More than 80% are now curable. And the UKALL just presented their data with about whacking 87% event-free survival. In Asia, we are playing a bit of a catch-up. Our Malaysia-Singapore study is about approaching 80% as well. And the TPOC in Taiwan has also been improving, and this has the latest results, say from McKay, actually has also achieved about 80% as well. So there are, as the various speakers mentioned, a lot of genetic abnormalities in ALL that you can see, and there is a distinct difference in prognosis. In like the BCR-ABL ALL is poor, whereas the very good groups like E2A PPX1, hyperdeployed ALL, and TEL-AML1 have remarkable 80-odd event-free survival just on chemotherapy alone. So these patients are more common in these genetic abnormalities are more common in children, and therefore children have better results because we have the easier part of the pie in general to do. Now, minimal residual disease based treatment is probably the way to go. It is probably one of the most powerful biomarkers defined. And the UKALL trial again shows that MRD is by far the most important. However, the NCI criteria still contribute to this role in general. In our own Malaysia-Singapore data, using minimal residual disease stratification, you can see that there is actually a huge difference in outcome between the patient's standard risk, intermediate risk group, and high risk group. And these are determined right from the beginning at 3 months of remission induction therapy. So it's like you're able to tell the future what the stock market is going to be, and hopefully you can invest appropriately in the appropriate treatment for the stock market in general. Now, in the Malaysia-Singapore group, we looked at a few factors. Number one, we wanted to decrease side effects of treatment, and there are some data saying that we can now start to decelerate treatment. That means we don't need to be so strong in terms of chemotherapy. So you instead, in the UKALL and the COG group, NCI standard risk patients can receive 3-drug induction therapy rather than 4 drugs. About 2/3 of the patient can receive just 3 drugs. The MASPOR group took it a bit further. We only give it in patients without BCR-ABL, and also good prednisolone responders in general. About 85% of patients receive only 3-drug induction in general. However, if you do this, instead of prednisolone, you need to give dexamethasone, because dexamethasone is probably more efficacious and more potent compared to others. Now, if you use 4 drugs for the adults, you must remember that dexamethasone plus 4 drugs in teenagers in the BFM trial have got much excess toxicity, and they have now decelerated backwards to prednisolone. And dexamethasone is better for T-cell ALL. In the Malaysia-Singapore group, we have no difference between the T and the B lineage ALL because of dexamethasone used up front. Now, so comparing our MASPOR results with 3 drugs compared to the BFM 4-drug regimen, you can see that our standard risk group patients and intermediate risk patients have not much difference in terms of percentages, and our outcome are comparable to the German-Italian group. However, for high-risk patients, you are going to trade off for high-risk patients for about 6 to 7% of patients. You have a poorer outcome because we started a little bit slower and less intensive compared to the BFM group. So majority, you can sacrifice, so to speak, the 6-7% of patients to save the toxicity for the 90-odd% of the patients that don't need for-drug induction. Now, the UKALL group compared this very well in the Lancet paper. Patients who receive standard risk regimens have much less toxicity compared to the intermediate risk or high-risk treatment in terms of infections, fungal, otherwise, seizures, thrombosis, avascular necrosis, and side effects in general. So by decreasing just one drug, plus, of course, minor other changes, the toxicity is very different. In fact, for our ALL patients in the MASPOR group, we can send home within 7 days of starting treatment because infections are actually much, much less with no daunorubicin. Now, why is this important for Asia? It's because in Asia we have a diverse economic and support available. For most countries, we do not have very good support, and therefore the take-off message is you can start slower so that you don't need to use so much antibiotics and blood support, and patients do not die of infection and bleeding complications, which can be up to about 30%. And that is the consensus statement that we made in the Lancet Oncology, the Asia Oncology Summit meeting in 2012 and published in 2013. The next part of the UKALL and the BFM group shows is that and the COG as well, the reinduction, although important, if you use one block of protocol 2, then you should be enough in terms of that. So the UKALL 2003 randomized between 2 delayed intensification versus 1 delayed intensification for standard risk group. They all do just as well. The COG group showed that you don't need 2 blocks of protocol 2 as well. However, in the BFM group, they use a shortened protocol 3. Instead of a month of dexamethasone, they use 2 weeks. And that shortened protocol 3 is insufficient if you just use 1 block. If you use 2 blocks like the MASPOR group and the ALIC protocol, then it is sufficient. So there are some minor tweaking that you can improve further in terms of reinduction. I believe reinduction is more important than induction in terms of treatment intensity, and you have to treat that with a little bit of care. Switching gear, there's a lot more data now coming out about Down syndrome with acute lymphoblastic leukemia. Dr. Kojima talked yesterday about AMKL in Down syndrome. Unlike AML, Down syndrome, my boss taught me, is that if it is ALL, if it's more than 3 years. So you have a Down syndrome coming to you in the clinic. If it is 4 years old, it is more likely to be ALL. If it is 4 months old, it is more likely to be transient myelopoiesis, for example. So there is, again, a male predominance in ALL in Down syndrome. In Down syndrome, also in normal children, but it is more pronounced. The UKALL data again show that outcome is much poorer, 65% compared to 87% for the group, and then in terms of a lot of treatment toxicity. So Down syndrome, you also should start on 3 drugs rather than 4th drug, because toxicity, death in induction is about 8.7% compared to omitting the 2nd drug. They have much more steroid-induced toxicity as well. Now, for the adolescent and young adult, the UKALL protocol and the other groups, as David have shown earlier on, that the pediatric inspired protocol has improved treatment outcome in general, but they are still a little bit inferior compared to that of the pediatric 1 to 10 years group, but then there is tremendous improvement compared to the UKALL 12 protocol in UK. So pediatric inspired protocol is better, and you can define a MRD standard risk group with excellent outcome for adult or young adults that is about the same as children, which is 93%. However, again, the young adults have got more toxicity of infections. Almost everything is higher in terms of toxicity except vincristine-induced neuropathy. So you must be a bit careful. Then recently described Dario Campana and Elaine Constant-Smith from St. Jude Children's Research Hospital. There is a type of ALL which is a little bit more premature and has some myeloid features we call early T-cell precursor ALL. These occur in teenagers and they present interestingly with lower white cell count compared to ordinary T-cell ALL. They have, of course, cytoplasmic CD3, which is a pan T-cell marker, but absent of 1A, 8, and then 5 is weak in general. They have either stem cell markers like CD117, CD34, HLA-DR, and has myeloid expression of 13, 33, 11, 11B in general. These patients in general have poorer outcome based on the retrospective data, mainly using prednisolone as part of induction in St. Jude and the Yeoh group. In our Singapore MASPOR group data, for very small number of patients, DEXA seems to be better and prognosis may be changed if you actually use a more intensive DEXA-based chemotherapy. So the jury is out, but it is good to incorporate some of these features in testing. Pharmacogenetic studies, David have alluded a little bit. In Caucasian population, 10% of patients are TPMT deficient, and if they are homozygous deficient, they have extremely high levels of thioguanine nucleotide incorporated into their red cells and a lot of toxicity, and you need to adjust it. In the Malaysia-Singapore group, we found that Asians have a different type of TPMT mutation. We have the STAR3C mutation compared to the STAR3A that the Caucasian have, other than the Indians. So the STAR3C is more common, and we have a STAR6. The frequency, fortunately, is only about 3%, so that in general, the risk of not doing TPMT studies in Asians may be permissible, in my belief, unless you face with toxicity. So if you have a lot of toxicity, do think about reducing the methotrexate dose and do TPMT genotyping. So in patients with TPMT deficiency, heterozygous, you need only about half the dose compared to that of the normal patients. The other thing that Asians behave slightly differently from others, we have studied two genes, the ABCB1, which is the MDR1 polymorphism, and the polymorphism TT phenotype actually has poorer outcome in the Malaysia-Singapore trial and just reported in BJC. The IL-15 polymorphism is also associated with poorer outcome. And in combination, these have an additive effect that seems to change in terms of the host genetics ability to handle drugs in general for patients. So now, what is the take-home message, therefore? MRD restratification for the major group has been now incorporated in terms of treatment for pediatric-inspired protocols. We do use quite a bit of early response to treatment as well. The incorporation of the NCI criteria, like the COG and the UKALL group, I think is important. In my misguided youth in designing the MASPOR study 2003, I dropped the NCI criteria because I said I have an expensive test like MRD and NCI, which is so cheap, which costs no money, $20 in Singapore because you do an FBC. It's not important, but it seems that I'm wrong, and we should incorporate NCI criteria in the first risk stratification, although you have an expensive Rolls Royce like I have. The poorer risk patients, therefore, would be NCI high-risk patients, Down syndrome, and David and others have, and Dr. Chow has mentioned BCR-ABL-like, E-cross deletion, amplification of the RUNX gene, and early T-cell precursor. So the moral of the story, over the last 1 hour, you are inundated with so much information, with so many biomarkers, so where do we start? And that is the problem that we have now. We need clinician scientists, translational researchers to change this into applied medicine, how to take all these biomarkers and put them in terms of treatment. Thank you.
Thank you for your excellent